let's get started anyway, and just welcoming you all back to PCMH office hours at the end of August. The summer weeks and season are just speeding by, but always excited to have you all on the call. Today will be a very timely call as we have quite a bit of information to share. We have our lovely Karen Vestaubert, Co-Imagine Health partner with us, the wonderful Sophie Katz, my partner and colleague, partner in crime, I like to say, on this PCMH office hours, and I also see my other colleagues from Chicanes on as well with us today. So we are going to be speaking about just some updates and questions that have come up around the New York State program. As we know, a lot of health centers are about to venture into annual reporting territory. We're then going to be talking about re-engaging patients, especially now as flu season is almost upon us and folks are thinking about how to re-engage patients, not just around care gaps, but actually getting their flu vaccine, which is very important, as we all know. And then, excitingly enough, we want to unveil to you all our SharePoint document repository. I want to give full accolades to Sophie for just being the architect behind this wonderful resource to us all, which will also enable you to post your questions, thoughts, comments, and see recordings and documents shared during these calls, but more about that later. I guess I'm just enticing you all around that. So I guess without any further ado, we can get started with our content. And as always, this call is being recorded, and feel free to chat your comments or questions in the chat, or of course, unmute yourselves and speak out. We always love interaction. So take it away, Karen. I guess the floor is yours.
Okay. All right. Wait. Hi, everybody. I'm, for some reason, on the last slide. Okay, so we got a lot of, feedback, questions, et cetera, around, after last month's little kind of quickie tour of what's new with New York State PCMH, NCQA, basically. And so we're going to do rerun from last time and open it up to questions, some items to follow up on. We're going to give you some examples that you can use to meet some of the required criteria. So we're going to do that, and then we'll go into a little bit, we'll go into our flu vaccine sort of, I guess, brainstorming session, if you will, and then we'll do the SharePoint. So please stop me if you have any questions. Maital or Sophie, keep an eye on the chat because I can't see it in my view right now. That'd be great.
And just so you know, Karen, we do have the polling questions ready to go.
Oh, yes.
So
Thank
let
you.
us know when you want us to unleash those.
Yes, I will. I actually have placeholders for those, so we'll be good. So this, again, I love this slide. Again, you've seen this before. This is a kind of reminding us why are we doing all this. You know, and yes, it's extra work, but it helps make us better at what we do. And we have some great data that I believe Sophie pulled together on a survey from y'all that shows, you know, the impact that the rewards and awards from PCMH have made are making on your practices. So we'll get there. But the New York State core criteria, behavioral health, emphasis on behavioral health, care management and care coordination, health IT, of course, and value-based agreement. So they've teased out these 12 from the NCQA standards. These are, I can tell you from my work across the country, not what other practices usually will use or do because they have not been given sort of the resources and encouragement to do so. So these are, I think it's fair to say, some of them are the harder ones. And those are your New York State requirements. It makes you guys, in my opinion, a step above, really, above the average PCMH recognized practice. So these are just quickie updates. If you can't find where are the annual and where are the new New York State criteria, there was an update back in July. Where are they? If you go to the NCQA page to download them, they're no longer there. They're actually embedded in the new version of the PCMH standards and guidelines. So they're actually, Appendix 7 is all about New York State PCMH. So if you're looking for those, they did not go away. And don't panic, they've been combined with what I call the regular PCMH, Appendix 7. So there's that. So they've added there's all these guides that unfortunately, those of you who have gone through this, you know you have to kind of cross-reference. So they've updated some of their guides. This is just a screenshot of what those look like. So you'll see the PCMH standards and guidelines, and where it has this little NYS in red, and on all of the little, guidance tables that NCQA provides, the little NYS, those are your New York State criteria. So instead of having them separate, they've put them all together in the PCMH with all the other PCMH stuff, and they've added the NYS. They've made it a little bit easier for the coming year for new practices that are going through New York State annual renewal for the first time. So if you are New York State recognized under the transforming, so say you went through PCMH for the very first time and you did the New York State, then you've already done the 12 required criteria. You can attest on your annual, which means you don't have to provide the data or the evidence for that. So that is new. So you only have to go through them once, and if you've already done the 12 and you're going through your first New York State annual, you can attest. So that's what this screen is about. I'm going to keep going, and I'm happy to, you can chat in or email me later, and if you have additional questions on this, but for the sake of time, I'm going to keep moving. There's something called transfer credits, also to make it easier for those of you that are New York State. So the difference between transfer credits and attestations. If you're already New York State recognized and you're going through your annual, you're going to get auto credit or transfer credit or whatever you want to call it for the 12. Other than QI-19, which if you can see down in the corner, still requires evidence, and we're going to give you hopefully some good examples today on what would work for QI-19. So again, always difficult getting the language straight, keeping it straight in your head. There's a lot of moving parts with NCQA, but just know attestations are for new practices, transfer credits are for renewing practices, and it is a way to save you time and effort when you are continuing to renew or achieve your New York State recognition. So here's a question that actually came up from last month, and I actually didn't know the answer, and I don't know everything I know from making a mistake or from having to ask NCQA, or I learned from you all because the questions you ask make me better. So again, do we have to do all of the 12, or can we attest for all of the 12, or what if we're already recognized? So there was a practice on the call and they were PCMH recognized. I don't know if they were New York State or not. So if you're New York State PCMH recognized, you went through the big process with the 3 check-in calls that's called transforming. And if you've been through transforming, you know what I mean, because it's the long one, it's the big one. It's where you have to get on the check-in calls with the reviewer. You do not need to submit evidence for the 12 New York State when you do your first annual. So once you meet the 12, whether it's on a renewal or whether it's on a first time around, you get auto credit or the ability to attest when you go to renew or re-up your New York State. So that's what this one is about. Again, with the exception of 2 criteria, this is good old NCQA, they're always keeping us on our toes, 21A and QI-19, which we'll go over. So that is a question that from last month. And then there's also something I wanted to share. It's called corporate credits. We don't ever hear a lot about this, but basically what this means is, I'm going to use Chautauqua as an example. Chautauqua has 2 sites that are recognized under New York State. They have a 3rd site that is not recognized at all. they're bringing that third site on right now. They're going to have to go through the big process with the 3 check-in calls. However, the corporate credits come in where you can get auto credit or attest to criteria if you already have recognized practices. So if you have 3 or 4 that are already recognized and 2 that are not, when you bring through the 2 that are not, you can use the corporate credit. There's something called the corporate credit table. I'm going to show you what that looks like real quick. It's this little screen right here, if you can see my PDF. And I've highlighted all of the credits that you can avail yourselves to when you're bringing through a new site. The ones that are in yellow, why is that? There we go. I'm scrolling the wrong way. Are ones where you'll get credit. So this is something that's actually not new, but I don't think a lot of people know about it. I don't think a lot of people use this. They just think, oh, we have a new site, we have to do everything, even though our other sites are recognized. That's not true. So you can attest, which basically means you're answering the question, yes, we do this, and you don't have to submit the reports and the policies and those kind of things. I just want to make sure everybody knew about that. And we can make all these little handouts here are available when you download your standards, but we can make them available to you on the SharePoint so you don't have to go in and hunt for them, if that will make it easier. Any questions? I'm going to stop for a sec. Anything? Hearing nothing. I will keep going. There's shared and site-specific credits. If you have more than one site, you can share whatever shared. This is a shared credit table over here on the right side of the screen. Again, there's lots of tables that that really, when you're working on this, you unfortunately have to cross-reference. There's not all one tool that has everything on it, which I've always found that to be a little bit discouraging. That's why I keep a notebook, and I actually do old school. I download everything on paper, I put it in a notebook, and I can flip through it. And of course I have these on my computer. Sometimes it's just easier to do it paper way. These highlighted areas here, you can share. If one site has an EHR, obviously all sites get credit. If one site does depression screening, all sites get credit. In a nutshell, that's shared credits. I wanted to point that out. Some are shared, some are site specific. And then here's some neat information from a survey that Jacani's did. Now the sample size is a little smallish, but I think 19, that's decent. I think in statistics they say you would need to have at least 30 for it to be a trend or to be a sample, whatever. That's okay. We're going to take this. This is great information from you all about the positive side of PCMH, which is the incentive dollars that you receive, and how you all are reinvesting those dollars in your practice to improve patient care, to streamline operations, et cetera. So you can read this for yourself. First of all, how many of you know where those PCMH dollars go? And depending on where you're at in the organizational chart or how transparent your organization is, you may or may not know. 84% said yes. I think that's pretty good. And then here's some interesting information on how those PCMH dollars are being leveraged. You can read this for yourself. I'm not surprised to see care coordination, care management, probably the most challenging in our busy world of medicine. Then staffing, that's great. You can put those dollars into hiring care managers, navigators, whatever, technology, general programming, and then reallocated. That means it goes into the overall budget, and we really don't know where it goes. And then this, I love this quote that was provided here. And these slides are great. Sophie, these I believe you did. These are very, very nicely done. And then what it's all about really is improving our quality of care. So here's some great data that was shared by you all on how being a PCMH and receiving those incentive dollars has impacted quality measures at your organization, which is what it's all about.
And if I may just make a comment, it's just so exciting to see how several aspects here feed into another. So certainly having robust staffing and staffing in place to really focus on your high need and high risk patients and moving the mark on different performance measures makes a difference. And also thinking about the diabetes quality measures, which many folks answered to in terms of PCMH investment helping to bolster, and thinking about that in terms of the diabetes action plan that we know all the health centers are tasked with doing from HRSA. So it's just very exciting to see all the pieces coming together and how one informs the other, and the bottom line, of course, is excellent patient care and just reinvesting in your staff and your technology and all other systems, and how that makes a difference in moving the measure, a needle, so to speak, on these different quality measures. So very exciting to see.
For sure. Yep. Congratulations for all your good work. Okay. My screen seems to be a little locked up. I'm going to escape, and that'll probably help. And, okay, so we got a request from last time for examples of what would meet QI-19. So I'm going to just jump to that while my PowerPoint is deciding whether or not it's going to cooperate when I come back on. So QI-19 is participation in value-based. You have to provide evidence of participation in a value-based arrangement or agreement. And it's one of the 12, and it's one of the 12 that you cannot attest for, and that you do not get transfer credit for. And then there's QI-21 is the other one, and that's your connectivity with a qualified entity or an HIE in the state of New York. But this is some examples, and this was kindly shared by Chautauqua, who just went through, and they were like, absolutely, please share. Where did that go? It's not that one. And then there is an example, it's going to pop up in a minute, from one of my Wisconsin practices. So this is a very long spreadsheet. Basically, this example is evidence of implementation. This is what they received from their partner, from their, this is a Medicaid value-based arrangement that one of my Wisconsin practices is engaged in. They get these very elaborate reports quarterly, I believe, on all of their providers. And so this is what we shared. I'm trying to scroll it down here. I think it's blacked out because I didn't want to share the provider data. Actually, it's locked here. Let me get this floating thing out of the way. There. Here's the physician summary, and et cetera. It's just a very long spreadsheet, but this is one example of what was used to meet QI-19. And this is from one of my groups in Wisconsin. It actually has somewhere on here. I probably won't be able to find it. I don't want to take the time clicking around, but it actually shows the dollar value amount of the award that they got. And so this is very transparent, but I did black out the providers, and you can see all their data. So there's one way you can meet it. So I know you all are getting reports. At some point in time, they may not come to you directly, but someone at your organization is getting reports on your performance. Here's another way. This is what we used for, here it comes. This is what we use for Chautauqua. This is, and there was an accompanying email. This is simply a letter from Fidelis Care about the contract. Welcome to our arrangement. This is acknowledging, et cetera, et cetera. This is the year. So talk to your C-suite or whoever is involved of your contracting, and if you can get a copy of the agreement letter, you can also use that as evidence of implementation. So those are the two.
So I have a quick question, Karen, regarding the VPP contract. So if you want, could you showcase like an updated letter? Let's say you have a continuous contract with the same payer. Do you have to show an updated letter, or can you show an old letter from the previous attestation? I guess that's really my question.
Well, Well, so this is a 2020 renewal, and this is a 2020 letter. So if I was doing 2021, they want to see that you're still engaged. So it depends on how long the contract is. So look right here where it says January 1 through December 31. That's calendar year 2020. So if I tried to use this letter for 2021, it would not fly. If the reviewer was paying attention, they want to see, you know, we're in 2021. Does your agreement go into 2021? So no, you can't. If there's dates, they want to see that it's current. So I would not recommend you use last year's letter for last year's contract period for this year's annual. And it depends on the reviewer. Some of them catch it, some of them don't. But as a best practice, I would say don't do it, because I've had quite a few people inadvertently upload documents that had the previous year's date on them, and they get kicked back. I mean, it shouldn't be a problem if you're currently engaged. It'd be great if you could just reuse it. I mean, I would love it, but no, it has to be current. And they also had some care gap reports that they shared, and they also had an email that they shared, just someone emailing back and saying, you know, here's your care gap report. And they showed that, but the letter alone would be enough. Again, it's just evidence. It's not a report. It's not a documented process. Evidence that you're currently engaged in a contract is what's needed for QI-19. Okay. So I hope that's helpful to, for those of you that had questions around that. The only other question, we got another question about uploading. When can we start uploading for annual renewal? For annual renewal, as long as you're enrolled, you can begin to upload or answer your questions or save your information at any point during the year. Again, you just have to watch your dates and make sure you're current. You know, it can't be any more than 12 months old or previous year. And then when you get ready to submit, at that point, you would need to pay your fees, where all other things, PCMH, they want their money up front. But for annual renewals, what I'm telling people is, hey, while this is fresh in your mind, you know, if you've just gone through an annual, or you've just, you know, brought one of your sites up, you know, get your annual going and start answering your questions, because a lot of it's attestation, and thinking about, you know, gathering your data. Don't wait until the very end. You can do it at any point during the year when you've got time, or when it's an appropriate time. Great time to do it is just after you finish the other one. You know, get that new one going, and throughout the year, make notes to yourself, you know, to grab that report, you know, however you want to do it. You don't have to wait till the last minute and put it all in 30 days before. You know, it's open all throughout the year, and then you'll pay your fees right before you submit. So that's a best practice, I would say.
And just to piggyback, Karen, I think you may recall last month there was some discussion about who shoulders that cost. And as you know, yes, the advice given is go to your HRSA project officer, yes, because I believe it's reimbursed through the NOI that way.
Yes, absolutely. And go to your HRSA officer, like, again, once you finish. So NOIs are good for 12 months. I found this out the hard way, like most things in life, right? I've had clients that are like, I can't get in, I can't use my NOI, I'm ready to submit, I'm at the deadline. You know, oh, they're only good for 12 months. Did you know that? I mean, I did not know that. I don't know if you all knew that. That's news to me. So every year, you have to request the new NOI to use for PCMH to keep your status current. And as you know, or may not know, some of you have had to wait, some of you haven't, depending on your project officer and depending on how backlogged they are at HRSA, it can take weeks for you to get that NOI. So again, don't wait till the last minute. I'm repeating myself. You know you're going to have to do your annual every year. You know, put it on your calendar. Request that NOI, you know, as soon as you finish last year. I know you're like, oh, please don't tell me, I just don't want to do this anymore, I want a break. But yes, give yourself a break, take a month off, put it on your calendar, and then request a new NOI for the upcoming year, because you don't want to wait until 30 days before you're going to expire, because chances are it's going to be held up on somebody's desk at HRSA. More often than not, I would not take that chance.
Thank you so much for that, Karen. I just want to relate to you 2 questions from the chat. So Jenna asks about one of their sites being closed. They moved their providers into their main building. How does the organization report the site-specific data, or can they just divide the data by providers that usually work in our secondary site?
Okay, so Jenna, your site closed permanently, or this is a temporary?
And certainly, Jenna, feel free to unmute yourself and elaborate.
Hi, sorry, it's a temporary closure, but we're not sure when we're gonna reopen at this point.
Wow, okay. Yeah, because of everything that's going on, I'm sure, and then a crazy environment we're working in. Okay, that is a great question that I don't know. So I do know this. I was on a call, actually it was a HRSA call. They had like a HRSA kickoff call. There's sessions that are just for FQHCs, and this was their kickoff, and the site-specific data, which is a challenge for a lot of FQs because the UDS is not site-specific, and a lot of them use the UDS, et cetera, came up. And what was said on the call, this is not exactly to answer your question, but in a roundabout way, that it was said by Bill Tulloch, everybody knows Bill Tulloch, right, or William Tulloch, if you're having difficulty getting site-specific data because you can't break it out, and I'm thinking of your situation right here, which is a very interesting one, that they will work with you, talk to, send an email through the PCS system, and they will make arrangements. Now, I don't know what that means, or give you a pass or whatever, so that you can create your reports. So that said, yours is a great one to submit through the PCS, Policy Clarification Support System, and ask that question. When are you ready? When are you due to submit?
End of the year. Our anniversary is January 1st.
Yeah, so I would definitely want to. Are you familiar with what I'm talking about, the PCS system? If you go in your QPass, that'd be a great way for you to access it. Yeah. Okay. Submit that question, and they'll kick it up the chain. You need to get that in writing, how you're supposed to manage that.
Okay, thanks.
Yeah, but yes, also know, I did not realize this, that they will work with practices that for whatever reason are having a difficult time. I mean, I've had practices go through heck and back because all of their reporting is lumped together and trying to separate it out. It can be done, but I did not realize that that's not like a hard stop for NCQA, and they'll work with you on that if there's just no way. So, FYI.
Jenna also had another question about annual reporting, and when it says option in QPass, what does that mean? Does that mean that you choose one to provide evidence for, or you submit for both?
So so there's an option in care coordination, I believe, the one that comes to mind. And they give you the option of reporting lab and imaging and and I forgot what they give you the option of reporting 2 together. I think it's lab. I think referrals is separate. You can either report referrals. They want to know what your status is on open referrals. So it's a date range, numerator, denominator, percent, because the assumption is, as a core, you are tracking all referrals, and you are tracking labs and imaging, and you're tracking care transitions. So I believe there's an option. You either can report lab, imaging, and care transitions. That's option 1, or you can report referral tracking. That's what that means. And there is, again, secondary guidance that will explain, again, all of these different pages of guides that NCQA puts out that speak specifically to that. But that's the or. And I just had one who did both. I'm like, or they did all 3. And I said, well, you didn't have to do that, but since it's in there, I guess you've already done the work, so you can go ahead and submit it. But that's what the option is. Pick one.
Thanks so much.
You're welcome. Okay, and just on the screen again, this is from last month. This is just new guidance from NCQA on that you must be connected to a QE, a qualified entity for New York State practices. There's 3 components now. Either if you're already connected, they want to see evidence of information, or I'm sorry, of implementation. There's a question to answer or an attestation. So if this is new for some practices, because not everyone in New York State apparently is connected to a qualified entity, and this is, there's the shiny, I guess that's how you say it, or if you're in with a non-shiny QE, you have the option to attest, and basically you're testing that within the next year that you will get connected to QE. So don't panic if you're not connected to a QE right now. That's what the attestation is about. You'll still be able to get your renewal, but they are going to expect between now and next time you renew that you will be connected to a qualified QE. And I guess you guys from New York know what that means. I had to look it up. But it's HIEs, I guess, that are vetted or linked into, I think, the Medicare CQM system, if I'm correct. Anybody on the phone, feel free to pipe up on that. But that New York State is requiring you to be hooked into one of those entities that is qualified to submit to Medicare and probably Medicaid in order to get your New York State dollars for being New York PCMH recognized.
I thought the CQM, the ECQM was a different measure from the one you have. There's an ARQI-5, which asks you about a attestation for the ECQMs. And I did have a question about that. Does that have to do with like MACRA and MIPS and those other quality things?
Okay. That ECQM, so you'll see that. So there's a couple things going on there. And I may be wrong. I mean, about the shiny QE, you guys, again, know more than I do. I just know that it's a qualified entity where you can report, I believe, in the Medicare format. And what they're getting at, so there's a couple different things. NCQA is getting ready to offer a distinction in ECQM reporting program for PCMH practices. So when you're in QPAS, you're going to see depression, NQF, whatever, ECQM, and then it says not active. That's because they haven't activated that program yet. But when they do, if you're submitting those ECQMs for whatever reason, for whatever program you're in, you can get distinction in reporting. So that's what that one is. And then the QI-5, is that what you were talking about?
Yeah, ARQI-5.
Oh, I'm going to have to look. It's a question about ECQM reporting, I believe, right?
Yes.
I'm going to have to look it up. Believe it or not, I don't have it. So again, they're collecting a lot of information in QI-5, in QPAS about your capability to report. I don't have the ARs pulled up here. So that's what that one is. It's just a question. It's not a right or wrong answer. They want to know if you are currently using the ECQMs and if you're reporting electronically, et cetera. So you're going to see several questions in your annual renewal about that. And that, again, you're not being evaluated on that, but they are collecting information. And in the background, my guess is that that all has to do with that distinction in ECQM reporting that they're getting ready to unveil.
Okay, thanks.
You're welcome.
And just to clarify, the other distinction program is behavioral health integration. So these are the two main distinction programs that NCQA PCMH program overall has unveiled.
Yeah, so the distinction, so you used to have distinction in patient experience reporting, if you all remember. That went away for whatever reason. That was, are you using the CAPS and this and that, et cetera. Now they have a distinction in BH, what they've had for a while. Any of these distinction programs, just FYI, if you're going to go for them, you have to do an annual for those as well to keep active, to keep that distinction. There's no extra reimbursement from HRSA at this time on the distinction in behavioral health. So it's basically bragging rights, but you may be engaged in some contracted arrangements with maybe a payer, or, you know, I don't know if maybe one of your value-based arrangements, that there might be some incentive there, either now or in the future, to have, you know, for enhanced reimbursement in those areas. That's where this is all going. And then the distinction in ECQM reporting, which I think is in here, you can read about it, but it's not active yet. That's what you're seeing. I think it's this one. When you open it up, it says not active. That's why you're seeing those questions in QPath on your, yep, here it is, not yet available. And you're seeing those in QPath. So you can read about it now if you want to, but again, they're offering this. And to my knowledge, again, there's no HRSA reimbursement for it, but you know, it may be applicable to other value-based contracts that you're engaged in, or for the future. I would certainly look to that, because that's where it's headed. Here's the ECQM. Okay, any other questions? I don't want to take up all the time. I mean, this is this is only interesting if you're currently working on your NCQA stuff. I know that. Otherwise, it's pretty easy to tune out, but it's very important if you're in the throes of, you know, trying to fill out your annual, or if you're thinking, or if you're doing a transforming. So we're happy to share our knowledge. Okay. All right, so Matal, we'll talk a little bit about vaccine guidance, and this is particularly around flu vaccine guidance during a pandemic. And the list that you're seeing on your screen, I kind of highlighted. These are topics that you all told us at the end of this last office hours series that you were interested in learning more about. And so I wanted to draw to your attention and over again that these are core components of a patient's center medical home. And so when we're talking about flu vaccine in the era of a pandemic, it touches on, you know, all of these areas really a little bit. And so that's why I put the highlighting here. It's population health risk stratification, which will show you from CDC. They're doing the risk stratification for you if you choose to follow the CDC guidelines. And then the other 4 topics we'll touch on a little bit from some best practices that I was able to gather from some of my practices out in California that are already ramping up for flu season, and from a great webinar that I attended yesterday from the Weitzman Echo series, and I'll be posting that link for you guys if you want to really get inspired and get some ideas about how to make the flu season vaccination actually work for you rather than against you. It was very interesting and uplifting to listen to, so we'll be sharing that link. All right, so here's the first polling question. There you go. Well, this is all of them, that's okay. You can fill these all out now, that's not a problem. Number 3 is more towards the end. So after we go through the information, I want to know if it sparked any new ideas.
And thank you for that, Karen. So certainly the first 2 are very relevant to the topic, and the audience could fill that out.
Yeah, so go right ahead and feel free to fill out number 1 and number 2, and then we'll get into some of the, I know it piqued my information. I'll tell you, back in the day when you all were much younger, because I know I'm older than probably everyone on this call, I was the lead for the H1N1 pandemic response at my health center where I work in South Texas. We have 5 locations in a semi-rural area. And that was my first experience with dealing with a pandemic in the middle of flu season. So this was kind of brought me back to that. And this is on top of COVID, we have some special considerations for sure. All right. Are you ready? Okay, 2/3 yes, 1/3 no. The majority of your staff will be vaccinated. Yes. So I know mandatory flu vaccines for staff has been a little bit controversial in the past. I'm really thinking that this pandemic is going to maybe change how we think about that going forward, but we shall see. Okay, close that out. Great. All right, so this is how the Weitzman echo started yesterday, and this got my attention big time because, you know, I'm kind of old. I'm an oldie. I've been around a while. I think I've seen it all in healthcare. You know, I've worked inpatient, bone marrow transplant at an academic teaching center, and now the tip of Texas in a border town in an F2HC. But hey, so why is it such a big deal that we vaccinate for flu, you know, during the pandemic? So this is what the doctors on the call pointed out, this table that I recreated here. And you can see it was pretty telling pretty quickly why this is going to be important, because the SARS and the flu have the same symptoms beyond the anosmia, which is loss of the ability to smell and taste, and the onset. So how in the world are we going to separate out whether someone, you know, has the flu or someone has SARS-CoV-2, which is the correct name, I guess, for coronavirus? It's kind of scary. So the first place I went to was to the CDC. When I was heading up the pandemic for the H1N1, I lived and died by the CDC because I didn't know where else to turn, and I was the DON at the time, and everyone, including our CEO, who was an MD, was looking to me to lead the charge. And I'm like, I don't know, I've never been through this before. Went to the CDC. So if y'all go to the CDC, if you haven't been on their site, there's tons of stuff on there, and there's a special page on vaccinating during the pandemic and flu vaccine during a pandemic. There are all kinds of patient handouts. There are videos. There are posters you can order. This is just one example of a tool. This is from 2018, but if you're big into checklists, this is a good checklist that I think would be useful, even though this is from 2018, and making sure you've got all the bases covered when you're planning for how you're going to manage flu vaccine. So I just wanted to share this and point out, go to the CDC website. This is also from the CDC website. I think I have the link on the bottom. Hide the meeting controls. There we go. So we talk a lot about risk stratification. We've done a lot of work and had discussions around that. This is a risk stratification that has been done for you by the CDC. When we can't vaccinate everyone all at once for many reasons, capacity, getting patients in, how are we going to vaccinate them without, putting ourselves and others at risk? And what about the supply, PPE, et cetera? This is a risk strat that is being recommended by the CDC. You can click on the links. The links are actually active. If you get a copy of this deck, you'll be able to click on the links and it'll take you to the CDC details around this. And I also put the link at the bottom. So I'm thinking about, where do we even start? You already answered this question. I'm going to pass through this slide. Thank you. I have, many friends who are not medical folks and some medical folks who don't believe in getting vaccinated for the flu. I can tell you, I feel like as a healthcare provider, and when I used to be the leader, especially during the H1N1 pandemic, we felt like we needed to set the example, because how can we ask our patients to get vaccinated if we don't, get vaccinated ourselves? So, the first person in line should be, in my opinion, I'm opining now, the providers and then the nursing staff. And that's why, getting your staff vaccinated is so important, and whether or not you require that and you want to be really strict and say people can't come to work if they're not vaccinated. That was one of the recommendations from yesterday. So I'm going to go ahead and talk to this slide. I have two practices in California that I just met with last week, and they are preparing. to do flu vaccines on top of their COVID testing and on top of everything else that they're being asked to do. These are some of the things that they shared with me that they're going to implement, and I'm hoping these will spark some ideas with you. So both of the practices are going to utilize text campaigns to their patient populations for prompts, for reminders to come in for the flu vaccine, for notifying patients when the vaccine is available, and just overall raising awareness. I thought that was great. They're planning on drive-through and curbside, obviously, because they're already doing drive-through. They're screening all their patients in the parking lot. And I thought this one was good, the fourth bullet point down. This is my practice called UMA. If some of you were on a few calls ago, UMA was actually on the call, and we heard from them about their some of their QI processes. They screen all their patients in the parking lot before they let them in. And so what they're going to do is, as they're screening patients for COVID symptoms, they're also going to be offering them the flu vaccine if it's appropriate. So they're already touching them anyway and checking their temperature. And so they're working on workflows right now to figure out how, who's going to do that, how that's going to go. You can read the rest of these for yourself, but planning now with clinical teams. If you've not met with your clinical teams already, they've already had some strategy meetings. They have a flu vaccine committee. Following the CDC guidelines. So I know there's been a lot of sort of political stuff in the news about the CDC. Do we follow or don't we follow? And this was a best practice from the Weitzman series yesterday. When staff are questioning you, when staff were questioning me, when my chief operating officer and my CEO was questioning me back in the H1N1 days, I turned to the CDC because, you have to have a standard, right or wrong. I felt like I had to say, I'm citing the CDC guidelines. If you want to read more about this, this is where you can go. So that was my savior at the time. And, I can't listen to, you have to pick, your standard that you're going to follow and follow it, because you are going to get questioned and challenged. So I'm just putting in that plug. Raising hyper-awareness among staff and patients, the curbside. I have one practice who has limited space in their parking lot because they're already doing parking lot clinics. So they're going to rotate to their different sites on different days for their flu. And of course, they're developing new workflows now.
There's a great question in the chat for you, Karen.
Yes.
So UMA, what texting platform are they using? Is it campaigns through their EHR or specific platform, patient engagement?
So both, yeah. So they are using a campaign through their EHR. They are on ECW. And I actually have two practices right now that are using texting campaigns through ECW. So one of them is using them for patient satisfaction, trying to reach patients that are as they're limited with them coming in, rather than coming in and filling out a form. And UMA is using their texting platform through ECW to reach patients for flu vaccine and many other things. And they just started doing this for patient surveys, for spot surveys, and it's been really neat to see the data come in. So is anyone on the call using text campaigns right now through the EHR or otherwise? I'd love to hear your experience. Okay. I thought someone was going to be.
Yes, I did too. Darcy, are you?
Darcy, please share. Okay, so while Darcy or others are thinking about chatting or being brave and actually speaking up, I just want to point out these best practices that really stuck out to me from the Weitzman Echo series yesterday. Using data. So we talk about using data to drive change. That was one of our ideas that we wanted to focus on this year. So there's a practice in, I think they're somewhere on the East Coast. I don't know if they're in Delaware, Massachusetts. They have multiple sites. This is an FQHC, and they have 88,000 patients. What they've done every year, and what they're doing this year, was they can drill down into last year's flu vaccine data to the point where they can predict, or they're trying to predict, do some predictive modeling, if you will, on how many patients they vaccinated last year, what months did they start, what patients came in during what month at that level of drill down, who are our patients that are willing and ready to come in now, and how many more patients do we need to try and reach this year? And their advice was, once you drill down to patients by site, patients by month, then you can focus your outreach efforts to those patients that you know are willing and able to come in for their flu shot. That was their recommendation. Don't try to get the ones that don't come in or won't come in or maybe don't believe in the flu. Start your campaign by focusing on those patients that are willing, able, and ready to come in. And if you know who they are, you could use your text platform, for example, if you have them set up, in such a manner to do targeted outreach. So you'll get more bang for your buck, because we all know that takes staffing, time, and money to do that outreach. So that was one that stuck out to me. The second one was they order whatever vaccines are available, this DON orders all of them. Because they don't know, you don't know, you know how it is, it's iffy. You don't know which vaccines are going to come in first, if you're going to get your full supply, what's going to come in when. So they order everything except perhaps the flu mist. That came up because flu mist is given intranasally, and then there's some risk there with COVID. So that was the other thing that stuck out. And then the third best practice that I thought was great, if you know what patients are coming in when for flu because you've done your data drill down, you can do pre-visit planning. And you can use the flu visit, if you have the staffing and the capacity and the workflows in place, to catch up on missed planned care, especially in the era of COVID. If they're having to come to you, to your parking lot clinic to get a flu shot, what planned care have they missed out on that you can capture while you have them there? And they're calling it their Flu and Fit program. And then learn from high volume visits, learn from this now, because you know a COVID vaccine's coming and they keep saying end of the year, beginning of the year. Chances are, if that's true, it's going to hit right in the middle of flu vaccine. So learn from your challenges from the flu visit and how we can do better or work in those COVID vaccines, because you know the F2HCs are all going to be tapped to be the vaccine leaders because you're tapped to be the testing leaders. And then one more thing, silver lining, and I know we're almost out of time. There has been some data showing, as you know, or maybe don't know, we're on the opposite seasons of the Southern Hemisphere. So it's winter right now in the Southern Hemisphere. That's my alarm telling me I have to hush. Dismiss. So they're seeing less flu right now in the Southern Hemisphere. They're in their flu season right now, less than anticipated. And so there is some anecdotal, which means it's not scientific or not proven evidence, that perhaps there's a silver lining in the fact that we have learned or are learning to social distance, to wear masks, to wash our hands, and to not congregate in large groups. And perhaps there may be a silver lining to the COVID precautions that we've been taking, even though you could argue the point that maybe we haven't done the best job, that maybe this flu season will not be as bad or as heavy as has been feared. So then there's that. I wanted to point that out. And that's what I had on the flu vaccine. There's so much more. And again, we'll be sharing the link to that. Listen to the Weitzman Echo series, listen to it on your lunch, listen to it while you're multitasking. It was very inspirational around how you can lead that charge in getting our patients vaccinated in this very critical time. It gave me some great ideas. So.
Thank you so much, Karen. And for those of you who are not aware, the Weitzman series is done in part with Community Health Center Incorporated of Connecticut, which is a large FQHC center that also has a research arm. So what's great about these Weitzman Institute weekly webinars is that they're very centered on FQHCs. And they just provide phenomenal information.
Yes, it was that health center that was talking. It was the Connecticut. Thank you. Thank you for that, Mytel. I was like, I knew it's somewhere on the East Coast. I couldn't remember.
I mean, they bring other guests external from their health center, but they're phenomenal because it is very health center focused and very focused on different departments and divisions, including behavioral health, primary care, adult med, peds. So highly recommended, and we'll have that posted in SharePoint. And I realize Sophie and I want to quickly present that, but I'm curious. I mean, this is a very timely conversation, and for some of you on the call, you may recall that last year there was quite a bit of movement around the anti-vaxxer movement, so to speak, and just patients not feeling comfortable getting vaccinated. Have you at all been addressing that issue with materials, with resources that you provide to patients either at point of care or through your campaigns? Just putting that out there to you all.
My child, I'll tell you, I asked Dr. Barth Rogers at UMA, their medical director, about how they manage the well, she didn't call it anti-vaxxer. I guess that's not politically correct. She called it resistant. It was a very nice term. And she said that
which is better.
There's all kinds. Yes, they're resistant to vaccines. That there's all kinds of studies and different, the cultural considerations, and they do not have one method. They take it on a case-by-case basis. And she said it was just a really tough one to deal with because of cultural considerations of both the provider, the staff. You know, they have a like all of us now, we're in a multicultural world. So there was not one answer, but I'd love to hear what others have done. Other than they sit down with them and have a conversation, usually it's the MA, and then sometimes it gets kicked up to the provider level to have that talk. Nobody.
Yes, and I wonder if it would be useful and worthwhile to have some of our health center colleagues just present on use of campaigns. I think that would be an excellent presentation and something to think about. So I realize we have a minute left. We always run out of time. And Sophie, Sophie to the rescue is sharing her screen. We just are very proud and happy to share with you all our SharePoint. So SharePoint is a platform through Microsoft 365, which basically enables us to create a document repository and discussion board available to you all. And how it works is basically we will be sending you an invitation to have access. So you see there's a little document section to your right there where Sophie has uploaded the recordings and I believe also the resources related to those calls. Thank you, Sophie, for clicking away and just showing all of those great resources. And you may recall, and especially during the spring, we talked quite a bit about team-based care in a hybrid model, whether it's via telehealth or in person. And those calls were certainly very well attended, and we have just uploaded all of those great resources, which you can find easily by month. We also have a discussion board. So this will really be a way to centralize all the questions and comments all of you may have for Karen or for each other about, you know, annual renewals, reporting, what's required for PCMH, along with just general questions that you may have. So this will be available to all of you as well. And I'm just wanting to mention, if you have a colleague or two or whomever at your organization who's interested in having access to this, SharePoint site or platform, please let us know because it is by invitation only, so we would have to send that link to that specific email. So please let us know. And if Sophie, you wouldn't mind just scrolling down, we have also added in just the opportunity here to see, a little bit up. The upcoming PCMH office hours calls, and just so you know, if you press on those links, you can then put those calls as standing items on your calendars. Thank you so much, Sophie.
Nice.
And then very quickly, we have at the bottom additional resources. So we'll be sure to add in the Weizmann Institute ongoing series around COVID and team-based care. We've included the telemedicine hack that Karen also shared with us that HHS has ongoing, that's excellent around telehealth. And just to remind you all, HRSA and NCQA have ongoing webinars and trainings related to sustaining your PCMH model. The next office hours on September 10th is dedicated to serving homeless patient population. So I think this is a very easy and easily way to navigate through this office hours platform. We didn't want to make it too confusing or involved. I hope you all agree, and please let us know if you have any feedback. We'd love to incorporate and just make this very accessible and usable for everyone. And yes, Patricia, I will give access to you to have access to this platform. So all of you who have registered and are on this call will be receiving an invitation from Sophie. So please let us know if you also have colleagues who would like access to this platform as well.
Yeah, so you'll be receiving an email with the invitation, and we highly recommend that you bookmark this page on your browser, whatever you use, just so you can always get access to it easily.
Great. I love it. It's nice and clean looking right now. Wait till we fill it up with stuff.
Oh, yeah. Oh, yeah.
Looks great.
Okay. I realize we're 3 minutes after the hour. It always happens to us. Thank you so much, Sophie, and thank you all so much for just your time and participation today, and we'll make sure to be in touch with you all. Thank you again.
Bye, everybody. Take care.
Bye. Bye. Have a good afternoon. Thank you, everyone, and see you in September.